Welcome to another edition of the Invisible Wheelchair Interview Podcast. I'm Donald Grodoff, family coach with FamilyOCD.com, FocusedHealthyFamily.com, and of course, InvisibleWheelchair.com. In the Invisible Wheelchair interviews, I get the wonderful chance to interview some of the experts with obsessive compulsive disorders, professionals that treat OCD, people who are going through or have been through OCD, parents and caregivers of those suffering from OCD, and of course anyone that advocates for treatment of OCD. My goal of these interviews is to inform people on all aspects of OCD and bring about awareness of obsessive compulsive disorder. The content, information, resources, and ideas that are talked about and brought up here in these interviews are not necessarily the views and opinions of myself, Family OCD, Focused Healthy Family, and Invisible Wheelchair Podcast, and I always recommend to seek additional professional help in finding solutions for yourself. You can find out more about me at FamilyOCD.com, FocusedHealthyFamily.com, and InvisibleWheelchair.com. This Invisible Wheelchair Podcast interview was recorded May 9th, 2019. Rogers Memorial Hospital, now known as Rogers Behavioral Health, has been known as a world-renowned beacon of hope for OCD sufferers. Their work with OCD sufferers, especially the ones that are extreme sufferers, has been phenomenal. And so it's with great pleasure and privilege that I get to interview Dr. Chad Wetterneck. Dr. Wetterneck is a licensed clinical psychologist at Rogers Behavioral Health and is trained at two leading residential inpatient treatment programs, Rogers Memorial Hospital and the Menninger Clinic. He has authored 70 peer-reviewed articles, mainly on OCD and anxiety disorder, and one book coming out this summer on assessing and treating sexual obsessions and compulsions. He developed and oversees the adult PTSD programming and augmented and oversees the mental health treatment for dual disorders programming at Rogers Behavioral Health, where he introduced schema therapy assessment and techniques. He is a member of the various organizations including the International Obsessive Compulsive Disorder Foundation, the International Society for Traumatic Stress Studies, and the Association for Contextual Behavioral Sciences. A graduate of the UW-Milwaukee Clinical Psychology, he taught in the clinical graduate program at the University of Houston Clear Lake prior to coming to RBH, and is currently the adjunct professor at Marquette University, teaching graduate courses on cognitive behavioral therapy and other related therapies. Join me now for that interview. So Dr. Wetterneck, thank you so much for being part of the Invisible Wheelchair Podcast, and I welcome you.
Thank you for having me, Don. I could tell your passion for doing this work in the emails, and I'm really looking forward to being able to share what I know and having you be able to help other people hear it as well.
So Dr. Wetterneck, what I'd like to do for my audience is to give them a little bit of a personal appeal for you. So maybe if you would, could you share a little bit about yourself, maybe a story, something about how you got started or something of that sort?
Yeah, I'm usually pretty open in these things too, so I'll try to keep it a little shorter. But I was probably a fairly typical college kid who wasn't sure what to major in and what I was going to do afterward. And at some point I decided I was going to go into business, and I got a degree in economics. And one thing I just decided is I really wanted to make sure I had passion about whatever I did. And once I realized I didn't know who I was going to work for, I actually re-enrolled in school and got another separate degree in psychology. And that kind of started me on my path of wanting to help people. I knew I always wanted to do that, and I really felt like psychology was going to be a way to do that. Perhaps I would have invented a widget to sell and become really successful at that, but I knew I liked helping people, and that was like a big purpose for my life. So I continued to pursue it until I became a clinical psychologist, and now here we are today talking. That also a little bit about how I got into treating OCD, because that's one of the areas I first started off in. And it was because in the early 2000s, when I was taking some of my courses and we were learning about evidence-based treatment and what's been empirically researched and supported, OCD had some of the best outcomes of all the treatments that we were learning about. So exposure and response prevention. And that combined with I want to be helpful, but I also want to know it's going to work. And so I got drawn into that and then started learning more and more about it, and having the rest of my education shape around treating OCD and other anxiety disorders.
Well, I have heard a lot about Rogers. I read a book by Janet Singer where her son was part of your hospital there, and but I don't know a lot about it. So I would really like if you could talk a little bit about Rogers. Maybe even tell a little bit of history to it, and what they do, what their specialty is, things like that.
Yeah. So Rogers has a very long history in working primarily in psychiatric mental health. And this started about 117 years ago. I believe it was founded in the 19th century. And it was kind of a classic, whatever you would picture a classic sanitarium to be in the late 1890s, that's what it was like. And if loved ones had some illness that they didn't understand, they were often dropped off, and it was supposed to be a place of comfort and rest and relaxation. And over the time, it's evolved greatly to where in the last 25 years, it still services only psychiatric mental health concerns, but it's really developed a specialty in a few of the different diagnostic areas that we see that are more common in the US and across the world. And it really focuses on specializing, giving high level of care, not just for the disorders, but in a really large, we refer to it as a large dose. So we don't do a once a week outpatient therapy, which is kind of the traditional way to do it. Our lowest level of care is typically about 5 days a week and 3 hours a day. And then we have higher levels of care where it's coming in for 6 hours a day every day, residential care, and then also we have some inpatient facilities. So I mentioned some of the specialties. We're going to talk about OCD obviously today, but we also have specialties in helping people recover from depression and mood disorders, from eating disorders, from substance use addiction concerns, and also from post-traumatic stress disorder.
In the description about Rogers, you talked about having pretty intense 3 hours a day, 5 days a week, 6 hours, etc. Now, do you consider that flooding?
No, I wouldn't say it's flooding. And, if your audience doesn't know what flooding is, that would be asking people to face some of their worst fears for long, protracted periods of time until they finally realize that their body will correct the emotional experience and not allow it to stay that anxious or disgusted or whatever feeling is coming up. What we try to do is develop a pretty thorough plan. And I already mentioned, or I believe that what we call it is we give a higher dose of it, where we're asking patients to work typically for a minimum 3 hours a day, whether they're with us 3 hours a day or not. We want a minimum of 3 hours of their time spent on doing their exposures, but we're going to start them at a level that we refer to as challenging but manageable. And so if you rate, many people get used to rating their anxiety from 0 to 100. We're going to start in the 25 and 30 area, maybe go up to a 40, but we want to ease people into this procedure so that they benefit from their early part of treatment, which gives them more faith in the treatment itself. And so we don't overwhelm them. We do know that flooding can be really effective, but when people find out that flooding is an option, they often don't come back to treatment. So we've kind of learned, we only use flooding if things aren't working through our regular methods and the patient still has to agree to it.
Yeah, because I would think that you have to really know the patient and understand the patient well to be able to use flooding, whether they can handle it, because it's very intense from what I understand.
Yes, yes, it would be facing the hardest fear you can imagine in your
Mm,
life, and just sitting with it until, yeah, and that's the problem. When you're the patient, you don't know what's going to happen. You're like, until
yeah,
what? And well,
yeah,
until your anxiety goes down. It's not going to come down. Like,
yeah, yeah,
well, actually will, but I know why you don't believe me.
yeah, yeah. To them, it's forever, you know.
Exactly.
Well, now we did, my wife and I did our own ERP here at our home, actually. You know, we were able to, because we homeschool and because of our work, the way I work and my wife works, we were able to work together and do it at home. What would you say the reasons are that people would want to come to Rogers? I guess, what's the difference on that versus even doing like a local residential thing?
Yeah. So I think there's a couple of angles from that I could talk about here. One of them is if you're already engaged in outpatient therapy and it's not working, well, that's a sign that you might need a change. And then it's trying to assess, like, what are those things that are contributing to it not working? Is it they're not actually practicing doing the exposure work enough? Is it that they have too much access to things that serve as safety behaviors or rituals for them? And there's a variety of things that could be going on. What are their relationships like in their home environment or potentially a work or school environment? You know, we end up seeing, if we talk mainly about children and adolescents, you know, every parent that cares about their child does not want them to suffer with OCD. They also don't want them to suffer with any anxiety. So there's lots of loving behaviors that would be very appropriate if the child or adolescent didn't have OCD, but eventually they continue. You start seeing some of that accommodation. You know, every caretaker and parental figure wants to try to prevent bad things from happening. So next thing you know, you're almost doing safety behaviors for your loved ones ahead of time. And it's a really hard pattern to break because you started off doing it because you care about them so much. And this is a way to show them love. To now stop doing that, it feels like I'm actually abandoning them. It feels like I'm actually being cruel to them. And many therapists who actually start off in this field, they have to go through those same feelings, even with someone that isn't their relative, their loved one. So it's challenging, and it's sometimes it's too much to ask a parent or a close family member to do, to stop doing the things that might actually be accommodating the OCD symptoms.
Would you be willing to share maybe an example or two of patients that you've worked with, what they went through, and then possibly the results?
Yeah, and I can speak to something that I think will be de-identified enough. I guess if I'm talking about the person that this was, they might pick up on it. But let me take you back about 17 years when I was a practicum student at Rogers. So it was kind of cool because I got to do some of my graduate training here because I wanted to know more about OCD. My first day I walk into the residential center, I'm following the behavioral specialist who's the main anxiety treatment planner and the person that takes the person through all their exposures. I'm following the behavioral specialist to an office that we're going to meet and discuss in, and I'm walking through a common living area, and I see someone with a badge on who clearly works at Rogers sitting down at a couch, and there is a man standing behind him. This is at the adult center now, with a knife next to the man's shoulder. And I can just see myself in my head. I'm following this employee, and I'm reaching out to try to touch him so I can point and say, you saw that, right? And we get in the office, the bare doorway shuts, and I say, that was an exposure? Really? That's a real OCD exposure? And he says, oh yeah, this person came in because out of nowhere, he's just started having thoughts of seeing images of things like knives and seeing very graphic things. And he started fearing that he was going to act on those images. He actually went to a number of mental health professionals and some physical health professionals. They didn't know what to say to him. They had him evaluated to see if he was actually safe or psychotic. His family, started questioning him, and the relatives of his family members that lived with him were basically saying, maybe you should move out and leave this person. And as it turned out, he was being misdiagnosed at the time. What he had was a very bad case of OCD, where he feared directly harming other people. And his history was one that he had never harmed a person in his life. He hadn't spanked his kids. He was like the least, and this is what we know about people with OCD, they're the least likely person to do what it is that they fear. This person's case, he had to work through his various fears, and we started him off with things like writing out the word stab, writing out the word killing, writing out I might stab someone. and doing that over and over again until, his anxiety was through the roof when he would do this. But eventually he would be able to like get bored of the activity. And then we said, well, that's what habituation is. You just got used to it. So congratulations on your boredom. That's what we're looking for. And we had to work our way up so that he had to read articles about people that actually did harm someone that they love. He had to watch movies in which, he probably watched some Friday the 13th movies, but those were actually easier to watch than movies where there was actual violence between, family members in which, potentially a knife was used. Still all cinematic in theme, but eventually he had to look at knives. He had to hold a butter knife. He had to hold a steak knife. He had to hold a butcher knife. And then he had to do that around our staff. And then his family would come and visit. We had to tell them that it was safe. And he had to be able to hold a knife, started with a pocket knife in his pocket when he was sitting in the room with some of his family members. And then he actually had to sit while we were doing some of our family session work and sit with a knife in his hands. Then he had to hold the knife as if it was poised and ready to be used, but not as close as what I described when I first walked in the OCD center. It was pretty amazing. He probably did about 6 weeks of treatment there. And he's like, I still see the images sometimes. I still have the thoughts, and I can't believe how far I've come in 6 weeks. And I'm ready to, take this now and go back home and work on it. Hopefully, in his mind, conquer the fear. And, we are still really clear of you're still going to see some images sometimes, and you're still going to have some thoughts, and you're still going to have some doubts. Is that helpful to hear the case in that much detail?
Oh, yeah. No, I think it is. I mean, because as you're talking about it, because my daughter used to go downstairs to our kitchen and pull a knife, one of the bigger knives out of the kitchen. And at first it scared that out of me,
Mm-hmm.
and I just, she threatened to kill herself. Mm-hmm. And she was only 8, or 9 at the time. I started realizing that she would do that ever so often. She never would do anything about it. But I started realizing that I knew down deep she wasn't going to do that. So yeah. I used to go, oh no, you don't want to use that knife. I'd pull this big, huge knife out, and she'd go, oh, don't even get that near me. And she'd run off. It just it changed the whole thing. But anyway, so I was thinking of that as you're telling that story.
It's so interesting too, because what you point out is how different people's responses are to the same types of obsessions. Sometimes, even if your daughter had a different obsession than what this man had. I've worked with people that are afraid that they might harm someone, again, with a knife. And their rituals would be go and grab the knife to see if they had an urge to actually do it, which terrified them. And they'd put the knife down right away because they were so scared. But, like some people actually approach some of the behaviors to test themselves, and some avoid it and would not come near it. So, no OCD looks the same to another.
At what point do you actually know when they're ready to be released to head out into the world or head home or whatever? How do you gauge that?
Yeah, so one is we have to try to identify with who they are as like a whole human being. So there's many things we end up learning about them, and part of learning about them is not just what is their OCD presenting as. Do they have other mental health concerns? Do they have any other like skill building they need to do? OCD, especially at a younger age, can really interrupt emotional and interpersonal development. So we want to try to equip them with even more skills, because we know that OCD can remit close to fully. And if you had it for 7 years, from ages 7 to 17, you probably missed out on some ability to like talk to your peers and be as emotionally receptive as other people, right? We try to assess all of these factors, including anything that's like a concurrent condition that they have, like depression. We've been able to develop through some pretty neat research, kind of like a goal or a cutoff. We know that when people achieve 70% of their hierarchy being completed, they are likely to maintain their gains a year later. This is some internal research we did where we looked at a number of factors. And we called up people, and we still do this in many of our programs. We call people a year later. We give them a really brief assessment. And then what we do is we use a lot of the data through clinical interviews and different validated research measures. We use that to help predict for each of our programs, and OCD was just the first one that did it. What does it take for people to get better? Is it they need to leave with their symptom level at a certain level? So that was one of the things in that study. Is it their OCD is measuring really low on the scale? Is it the number of days they were there? Is it the drop from when they first came in, they were at like a severe range and then they dropped to a low range? We put in all of these factors. We ran some statistics on it. And the clearest factor was you needed to complete 70% of the hierarchy that you were assigned to do.
And that's kind of like a list of their triggers, I guess, is what you're talking about as far as hierarchy.
Right. Yeah. So their hierarchy, for most people with OCD, that's most of their treatment plan is what are you avoiding? And if you avoid it, what safety behaviors are you doing? What rituals are you performing? And how hard would it be to not avoid or engage in this without doing the safety behavior, and then rate that on a scale? And so similar to what I said, rating a scale from 0 to 100, yes, that's finding out their triggers and writing it clear enough. Because if you just say encounter something that you fear, you really do need to write and don't wash your hands or and don't ask for reassurance. Or sometimes they're like, well, you didn't say I can't wash my hands. Good point. We'll correct that. But yeah, it's clearly written out instructions on what we ask them to do. And then with the directive of, hey, stay with us until it goes away by itself. The emotion goes down on its own.
Well, the other thing that just kind of came to my mind, because like I said, I read Janet Singer's book, and she was talking about, are the parents, how involved are the parents in the treatment itself?
So, we have different levels of care. So we have an adult center, an adolescent center, which there's only 2 of those, I think, in the Western Hemisphere. And then we have a child center, which I think might be the only child center in the world that focuses just on OCD and its related conditions. It's really essential no matter what the level. And we do different things in different programs. But in our child program, which is roughly like ages 8 to 12, sometimes 13-year-olds might be in there too, depending on where they're at developmentally, we try to do at minimum 1 weekly family session. And oftentimes it's remote. It could be through video, but at minimum, it's going to be on phone. We also offer them to either come in or through video or phone. We do something called Parent University, where we have a 4-week schedule of trainings that we do to help parents understand. And if they can be on site or even be on the same call, they can hear other parents ask questions and learn and be able to have the shared experience. They don't feel like they're the only ones. I mean, I don't have to tell you this, but whether you had 1 child or 2 children and you knew it both at the same time, you don't know what to do. You feel pretty alone. You question, what did I do wrong? What could I be doing better? And most of all, how do I help my child? And so this gives them, so not only the family work centered around their child, but also to be able to have a little sense of community that, hey, like there's many families across the US, because most of our folks at residential level are not coming from Wisconsin, where we're primarily based. They're coming from all over, including sometimes Canada and the Caribbean, sometimes from Mexico. So the shorter version is like once a week minimum family sessions, encouraging also for visitation. If the family lives far away, we're hoping that they can plan a time where they would fly in or drive in and spend a day or 2 or 3 with their child or adolescent, make sure that they're learning the skills that we're trying to teach the child. But it's so important that the parents become a behavior therapist. We ask all the adults, we say, when you walk out of here, we want you to be your own behavior therapist. Not because we don't want to see you again, but because, we hope that you're doing well on your own. But the parents of children and adolescents, we say, you actually are going to learn how to be a behavior therapist, because you have to for this treatment to be successful.
And I've kind of taken that and I do some of that work, try to help others with that. In talking about the parents, do you do anything? It sounds like some of this is part of what you were just talking about with the parents coming in through video and all. But, as I've learned, and one of the reasons I call mine family OCD is it's really not just the one person that suffers, it's the whole family. So do you do much as far as helping with the anxiety of the other members of the family?
Yes, to some degree. So we always have to recognize that, our identified goal is to make sure that the patient is receiving the treatment they need. And then to some level, we are going to either make suggestions or give some sort of coaching that will help the other people that are helping raise the child or adolescent, or if it's an adult living with them, encountering them on a regular basis. We frequently recommend, if people are really struggling with this, is also to see a therapist along the way. However, a lot of things that we might have to coach some relatives on include being able to habituate to your child or adolescent in distress. Like the process that your child is going through and we're asking them to do by doing their exposure work, you have to do the same process, because you can say, I've already been in distress, right? But you've always been trying to plan and problem solve it, and you can't problem solve OCD. You have to not do anything that feeds into OCD and the warnings it's telling you to do in order to stay safe. For many people, sometimes we give this advice, whether it's a child, adolescent, or adult, and they're not willing to work on their OCD. We will say it's really important for you to still decide what would make your life meaningful outside the context of that loved one and to do those things. You have to do things that include self-care. And if you've spent the last month, year, or decade or two trying to keep your loved ones safe and they're just not willing to change, then you still have to try to maintain some semblance of a life outside of that. If that means invite people over to your house so that you have guests and you can, I don't know, watch Games of Thrones or play cards or whatever people do nowadays for fun, or you go out to dinner, you go for a walk, you do what you have to do to take care of yourself. And a couple of things happen. One is, the person sees you're not around to accommodate them all the time. And I'm sure they will have some choice words for you that will really pull at your heartstrings. But they start realizing the effect they have on other people, and you are taking care of yourself, making yourself more effective. And you show that you're not going to it's not them controlling you, it's their OCD. You're going to show their OCD that it doesn't have a complete grip on you and the entire family when it has in the past.
Any advice, anything you might want to add in this?
Yes.
For parents, for the person with OCD, etc.
Yes. The first place I would start is looking at, if you have access to a computer, looking up the International Obsessive Compulsive Disorder Foundation. They have a list of people that have been trained through 3 to 4 day institutes with ongoing supervision how to treat OCD. You want to get a specialist for this. You cannot rely on someone that treats OCD in 5% of their practice. It really needs to be something that this is my main area. You have to know that there's only one very well-validated treatment for OCD, and that's exposure and response prevention. And this website will provide you with a list of people that do it. It also provides questions that you would want to ask a therapist, really to check and see if they list one of their 30 specialties as OCD. How do you know? Because we see plenty of people that say they've gotten exposure and response prevention or saw someone who knew cognitive behavioral therapy, only to find out that when we say, well, what was on your hierarchy? What exposures were you doing? They're like, oh, we were just talking. We weren't doing exposures. We're like, okay, well, maybe you didn't get there yet, but you weren't doing exposure and response prevention. I would use that website for a number of different things. I don't want to say to diagnose oneself, but the rates of people that go in to a medical health professional or even a mental health professional and get misdiagnosed with OCD, and the amount of time it takes for them to get the proper diagnosis range from like 7 to 15 years. And that's a long time to sit with something and feel like you have something else. And there's some pretty terrible presentations of OCD. They're all terrible, but there's some that people are less willing to talk about. Like, I don't want to say that this is easy, but most people will say, well, wouldn't you rather be clean and avoid being touching something you think might be diseased? Well, that's an easy sell, and people are willing to talk about that. But when it comes to the example I brought up, the man who thought he might harm someone, when it comes to sexual obsessions, where people are questioning their orientation, and then they get told, well, maybe you are gay if you are straight, or straight if you are gay. And then they start doing all this other types of therapy for parents who have young children, little babies, and they're cleaning their little baby's bottom, and they have this thought of, I don't want to stimulate my child or clean it too much there because that's their private parts. That's sometimes the beginning of their OCD. They're not getting sleep. They have this extra responsibility, and they're touching someone else's genitals. And next thing you know, they have OCD within a couple of weeks. So there's these things that people don't want to talk about because it's really taboo when it has to do with like violence, anything sexual. So just know, I want people to know that it's contamination and fear of something happening because you don't do something correct are very common in the most common presentations of OCD, but there are resources out there that give you a much wider breadth of how this can look. Please check out that website. Rogers may have additional materials on their website, but I would actually recommend them as being like the first go-to I would send someone to so they can weigh their options. How
would my audience that's listening to this best to get a hold of of Rogers or yourself to begin treatment or whatever, for whatever reason? What can you let us have some of the information about what's the best way to get a hold of you?
Right. So many of us know us as Rogers Memorial Hospital. It's probably important that I let you know we just rebranded our name in the last 30 days. We're now Rogers Behavioral Health. You should be able to find us on the internet using either Rogers Memorial Hospital or Rogers Behavioral Health. There are numbers on that website that tell you who to call in order to get an admission screening. Now, I can tell you off the top of my head, though, if you're in Wisconsin, you would call 1-262-646-4411. But if you are not in Wisconsin or you don't want to be billed for long distance, you should be able to call 1-800-767-4411. And then you say, I'd like to talk to someone about doing an admission screening. And you will get routed to someone instantly who will ask you, has been trained to ask you the right questions. So we know that you're in the right place and that we can help you determine what the right level of care might be for you or your loved one.
And I will also have this information up on both the FamilyOCD.com site and the InvisibleWheelchair.com site too. I'll have all locations up there for you. Dr. Wetterneck, thank you so much for being part of this. A lot of good information that you've given us. Being able to understand and know your place there and what you do is really, I think, helpful even for me to be able to tell others, but also for my audience. So again, thank you for taking the time today to be part of this.
Don, I really appreciate the opportunity, and I'm thankful that there's people like you out there that are helping get the word out, because we need more of you to help all the other families out there that are currently struggling and maybe even not know what they're struggling with.
This concludes this podcast. We really would appreciate your comments. Simply leave a comment at www.invisiblewheelchair.com. There, you're able to submit a comment that will help us determine future podcasts. If you or someone you know would like to be a guest on the podcast, please email Don at invisiblewheelchair.com. Remember, there is a corresponding tapping recording for each of the podcasts, with the exception of the interview podcast. You can find these tapping recordings and archive past podcasts at www.invisiblewheelchair.com. Finally, there is relief for OCD, and we at FamilyOCD.com and FocusedHealthyFamily.com can help you find that relief. Again, you can contact us through those sites, FamilyOCD.com or FocusedHealthyFamily.com. You can also find us on Facebook at Invisible Wheelchair Podcast. You can find us on Twitter at InvisibleWheel1, that's the number 1, or at FamilyOCD. So thank you for listening. Keep tapping and transcending your life to new heights.